Hi, everyone. This is Dr. Janice Makela, and this is Questions and Answers with Dr. Makela. Um, we are live right now on LinkedIn, YouTube, and on Twitch, taking your questions about cannabis and geriatric medicine and hospice medicine. Um, I was alternating them every other week, but it seems like people ask questions, so let's just whatever you want to ask about. Let's go ahead. Welcome everyone. We'll start up a little bit just of some humorous stuff because I know it takes a little bit for people to log in and to get here and stuff, and I don't want to be throwing off all the cool stuff when no one's here to hear it. So, anyway, the funny thing, so I told you I was on Twitch. Now, Twitch, a lot of you might not be very familiar with, is really a little bit more of a Gen Z, maybe some millennials, I'm sure, some Gen Alpha even, streaming service where it talks about a lot of times gaming is the main thing. People will go on and they will game stuff. I also see a lot of DJs and occasionally different sort of talk and sort of engagement shows. This is kind of a not common thing on Twitch, but I thought I'd try it out. Turns out Twitch is actually really canna friendly. So, um, they don't block you for talking about cannabis. So why not? Hence all the humor I've been making about, ooh, should I play video games while I talk about this? So that's where that's coming from, is the whole question about Twitch. I did actually see that Stardew Valley has an mod. So Stardew Valley is a video game. It's kind of a cute little game where you grow farm and you make friends with the community and you mine. And of course, there's some, monsters you have to fight and you fish and stuff like this, right? Um, and it's in the category of games called cozy, kind of like Animal Crossing is very similar in sort of the feel. Anyway, uh, but one of the things that Stardew Valley has is you can put mods on it, so people can do a little DIY changes to it. And so, anyway, I found indeed they have not one but several different mods of where you can grow cannabis and sell it in this very idyllic world where cannabis is perfectly legal and everyone uses, everyone, uses it without a problem, and you can make your own strains, and you can. The doctor sells it, the general store sells it. You know, it's this nice little world where everything's perfect. Um, Conversely, there was another game called Schedule One, and that one is more like it's 1985. It's completely illegal. The feds are coming out to get you. And as you grow stuff, you risk being raided by the cops. And I joked a little bit about playing that one while talking about the need for rescheduling. And actually, maybe that's something to talk a little bit about. When we talk about rescheduling, um, what does that mean? Yeah, maybe if you're in the industry or if you're in medicine, you know what this means. But when the FDA talks about scheduling, there are what's called scheduled drugs, and they have sort of rules about what can be prescribed and how you prescribe them. Um, so a Schedule One means that I can't prescribe it. It's illegal. There's no reason we would ever have this as a drug, and doctors can't prescribe it, and anyone using it is completely illegal. That's Schedule 1. Marijuana is Schedule 1. Cocaine is Schedule 2. So, Schedule 2 are things that are just like a little bit more riskier. Um, they're going to be a little bit more scrutinized, but technically, I could prescribe it. Now, mind you, if I'm giving you cocaine scripts every week, the DEA is going to be onto that. That's not something that's happening. There are extremely rare circumstances. Nosebleeds, oddly enough, and it's kind of an old school eye surgery thing too. But I don't think they use that as much. But nosebleeds, actually, in severe cases of like hemophilia, where the bleeding doesn't stop, cocaine will actually cut off that blood supply um, to the nose, and so it's considered a legal drug you can get. Um, but yeah, by the way, that's why it's also you hear about cocaine nose, people who sniff it and then their nose collapses because the blood supply to the nose eventually cuts off and the cells inside the nose die. And not a pretty thing. It also does the same thing to the heart, which is why, like when you see people who have been doing cocaine for a while, they invariably have really bad heart disease, and so that's not a good thing, you know. So cocaine is Schedule Two. Um, morphine, opioids are, in Schedule Two. Schedule Three is more like Vicodin, considered the weak opioids, stuff like that, are Schedule 3. And then you go down to Schedule 4 and 5, and I usually don't have to worry about those too much because they don't really require a lot of extra stuff, but it still needs a doctor's prescription. It still needs a little bit of extra, scrutiny. But generally speaking, that's what we're talking about when we talk about the different prescriptions. And so it's crazy. It is beyond crazy that I can prescribe cocaine, but I can't prescribe marijuana technically. That the DEA doesn't allow that. Now, Schedule 3 is not necessarily the best option either, because when we're talking about Schedule 3, what you're talking about is making it legal if you actually have a pharmacy making it, right? The way we do things in the States here, where you have a state, dispensary and a doctor's, permission to use it or whatever, because we technically aren't prescribing it, right? So we just have to give permission for it. And that's a whole other thing, right? Um, Schedule 3 allows big pharma to come in and say, okay, we're going to do some testing. We're going to do some phase 1, phase 2, phase 3 testing, get FDA indication, and then send our drug reps to have doctors prescribe it. If that's what it was, that'd be great. But I think part of it is that, big pharma's not in this right now. It doesn't seem. You got a couple companies in Europe, but we'll see. But the Schedule 3 is not a thing yet. Um, and of course, they've been holding it up. But the FDA, has been taking their sweet time. Now, there is a group called Americans for Safe Access, and they want things to be Schedule 6, which doesn't exist. Yeah, you say it's not going to work, right? You don't think the Schedule 6 is gonna work, or do you think that the, Schedule 3 is not gonna work? Because Schedule 3 has a lot of problems to it. You know, 1, most of the way we do things, it still would be considered illegal. 2, it's not, you'd have to be trusting pharma to come in and actually do things. 3, it still doesn't solve the banking issue, deschedule. So you would just rather have it be descheduled. And I agree actually. Again, there are so many other drugs. Yeah. I mean, at least, I think they talk about, yeah, you say three's not going to work, right? And I think I think there's really issues with it. like I said, I know one group called Americans for Safe Access wants to create an entirely new group just for cannabis where you can kind of look at, make sure people aren't, abusing it or whatnot, but at the same time using it medically and stuff like that. I kind of like that idea. You know, of course, you'd have to kind of set up what rules are you talking about and how you're going to do it. But I think we need to really talk about that. Or, like you said, just completely deschedule it. You know, it is true. Cannabis doesn't have something, you know, no one dies of cannabis overdoses. Um, in terms of safety. I mean, I'm preparing for, I'm right after this going to be doing a podcast about, with someone who's a sleep specialist and talking about cannabis and sleep. And I don't want to give away all my talking points on that because obviously, when she publishes her podcast, I want you to come out and see that. Right. But when you look at the sleep pills, right? I mean, benzos, most people try not to use those anymore, but it still is a very frequently thing. Um, when you talk about that, the side effects and the falls and the overdose risk, right? Not to mention, then you have drugs, Zolpidem. I'm trying to remember, you know, those types of drugs where you wake up in the middle of the night and you end up, you can drive your car. I know people who have woken up in the middle of the night and eaten their leftovers from dinner and then woken up in the morning and wondered why are there dirty plates on the counter. So that's um, Ambien, right? That's one of the problems with that. We don't have a lot of great sleep pills. Cannabis in the realm of things is not necessarily the worst option. Um, Cannabis is a great harm reduction tool, right? So opioids. Now, opioids are something I know very well. As a hospice doctor, I have prescribed more opioids than most doctors. I once got a letter from the state of Illinois telling me, Dr. Makela, we want you to know that you are in the top 5% of all prescribers of opioids in the state. You don't have to do anything to this letter. We just want you to know that we know. And I'm like, I darn well better be. I'm a hospice doctor in one of what was then one of the larger hospices in the state. I probably wrote over 1,000 scripts that year, because everyone on hospice got a little jar of Roxanol. And, what you do in hospice is you don't always have to take morphine. You know, you don't take morphine all the time. It's not like, oh, take the morphine. It's obviously if you're in pain, it's there. But a lot of times at the very end of life, in the last couple days, people do get pain or they get trouble breathing. It turns out that morphine is actually chemically related to cough syrup, and or maybe the other way around, you might say, right? And so it works on some of the same things in the chest wall to help decrease some of the irritation, just like that cough syrup kind of decreases that irritation that makes you cough. Morphine is very good at that, and it decreases your coughing. Um, Among others, I mean, if you have a bad cough, they give you codeine. Codeine's just morphine light. Um, Codeine is the delta 8 of the opioids. It's the, you know, quite literally. Um, and so the codeine, lowers the cough, morphine lowers the cough, and that irritation. So at the end of life, when people maybe are breathing really, really fast, super fast, like 50 breaths a minute, way too fast, or they're breathing really agonal and it looks uncomfortable, morphine can help that. And so we keep a little bottle of morphine about this big and we keep it concentrated so you can just give a little bit at the end of life. And you give it and you soak it in and you just give it whenever they look like they're uncomfortable. And so everyone gets a little bottle like that. And and because of that, I get letters from the state telling me, "Oh, Dr. Makela, you give," you know. And I'm like, "Yeah, I better be." But and you are right about cannabis as a bronchodilator. We'll get to that. That's a good point. You know, but the thing about morphine and cannabis is morphine is great at the end of life. It's great for pain. It's great for certain things of pain, but not chronic pain. That's how we got into this whole epidemic of opioids being overused, right? Um, so cannabis doesn't have that type of you don't get these overdose deaths and stuff like that with cannabis. Um, Cannabis is actually works on pain just like opioids, but in a different spot. Opioids work more on the spinal level. There are some stuff in the brain, but at the point where pain is transmitted from the extremities to the spine, then up to the brain, that's where opioids. Cannabis actually has some receptors in the brain. It also has some elsewhere, of course, but in the brain. And the other thing is that cannabis has a little bit more receptors, I think, in the emotional. So one way I often describe it is that when we're talking about acute pain, or severe pain like a surgical pain or something like that, you're going to need morphine. Um, Cancer, tumor pain, probably going to need morphine. Cannabis, though, one, because of its CB2 inflammation effects, actually decreases the inflammation and the irritation, and that way helps pain. The second is in your emotional parts of the brain, in the deep parts of the brain that deal with emotion, you have a lot of cannabis receptors. And I think it decreases the suffering of pain because pain and suffering are different things. And so you might be experiencing the pain, but you care less about it. And so, yeah. Anyway, so the nutshell to your point about harm reduction is that there are studies that show that people who are using and overusing and abusing opioids and supposedly for pain, right? These back pain patients who were given oxy back in the day, right? That they can actually come off of it or significantly decrease the amount of opioids they're using if they have cannabis. And it makes sense because it's actually acting at a different point in the so they're synergistically working together to block that pain. Um, and again, that sensation, I think a lot of times I see with opioids, people get a great deal of anxiety of, oh my God, it's going to run out and I'm going to be in pain and I'm going to hurt. And I don't think cannabis quite creates that degree of anxiety. It's people are a little bit more chill. And I think that's to the benefit, right? Uh, Cannabis is a bronchial dilator as well. Oh, yeah, I can click on, hang on here. Cannabis is a bronchial dilator there. Yes, as well. Exactly. You know what? CBD. I was talking to some people who are actually working. They're getting FDA approval on it. Hopefully, they do. Of a CBD to actually help with pulmonary hypertension. Um, and then also, yeah, there's a few things that are bronchodilators. Some of the terpenes. I was reading a lot about pining and the terpenes, some of them have some studies from pre-cannabis because they're not, or I should say, outside of cannabis, because a lot of those terpenes are actually in other plants. So rosemary, lavender, pine, um, sage, all have pining in it. That whole kind of family of scents of kind of piney, sagey smells, rosemary, lavender, right? All that together is pining. And so, and one thing that surprised me when I read that was, yeah, pining is a bronchial dilator. And now, I think there is some evidence that people who chronically smoke cannabis do are prone towards bronchitis. And that's where you get kind of this irritated phlegm that can build up and cough. And it can build up and over time kind of tighten up the airway as that inflammation creates some problems. And you can get chronic bronchitis. And I think there is some rising evidence that if you smoke cannabis consistently, every day, regularly for 40 years, that you're going to get some bronchitis. uh, the data about full blown COPD, which is sort of the next step up where it's like really bad lung disease, you know, um, bronchitis isn't great, and bronchitis can be a part of COPD, but you can have sort of a sub COPD bronchitis, um, where it doesn't quite qualify in the breathing tests for COPD. Um, that COPD doesn't isn't showing up as much as we might expect. Now, personally, I think part of that is also when you're looking at smoking, people who smoke, they don't smoke one cigarette a day. Most people who are daily cannabis users don't even smoke a joint. Many maybe smoke a whole joint, but many don't. And even still, is even less rare or less common, excuse me, would be someone smoking, more than one. So, you know, y- when we talk about a pack of cigarettes, that's 20 cigarettes in a day. You know? So, one pack, two pack, pack and a half, whatever people are smoking, that's nonstop every day, 20 of those. So, that's a lot of damage. And I think simply the reason we're not seeing a lot of the long term lung damage in smoking cannabis is volume. We're just not seeing, people just don't smoke 20 joints in a day, most people. You know? um, and like you said, I think there is also there's some data that the we do have cannabinoid receptors in our lungs. Like I said, there's some people looking at CBD and how it's actually helping. Um, and like you said, cannabis is a bronchodilator along with the terpenes. So that is true. The other thing, let's see. So we were just talking about opioids, right? And how that can help and pain and stuff like that. And so I would say, let's see, what do we talk? So I would say that opioids, you know, yeah, so many things to say. Um, that all just hit me at once. Just the fact that they're not more restricted. But you know what? There was a time in history when I was a young doctor. I know I've been practicing medicine for 20 years. So when I was a young doctor, just starting out, they had just changed the rules. You know, there was this kind of back and forth. It was like, ooh, opioids are bad. And like 20, 30 years ago, you had a hard time prescribing opioids. I even remember it being this real quandary about cancer patients. They're like, cancer patients can't get their opioids. And then you go the other way of saying, okay, yes. And in fact, in that time, you had to write opioid prescriptions in triplicate. There'd be a special form with little carbon back when everything was paper, right? With two little carbon copies that you would have to write, and you'd have to do these forms in a special triplicate form. They purposely made it difficult so that you couldn't prescribe as many opioids. But then there came the outcry, all these people with cancer who were dying in pain, and it was very, very, very real and sad, right? And so they changed that. And then you had drug companies come in and say, "Oh, look, OxyContin. It's not as addictive. It's great for your back. It can help back pain." And all these people coming with back pain. And of course, that created the whole opioid epidemic, right? Where people were getting addicted to prescription opioids. And so that kind of back and forth. And then in it, along with that came the whole pain is the fifth vital sign. Are they in pain? And should we give them something for pain? Right. And so that kind of back and forth of figuring out where do we go. And I sometimes see that with cannabis, I think. Now, I think we're kind of in a phase right now. Obviously, it's still FDA, is making it it's Schedule 1. It's still federally illegal. We're so used to talking about all the restrictions on it. But I think it's also important to understand that while people don't die from it, there are some people who don't benefit from it and should not be on it. You know, Schizophrenia, bipolar. I would not. There are some rare cases that the psychiatrist can, talk about. Um, but I was reading a case of a psychiatrist who was explaining that she's had a very small subset of patients with schizophrenia who were self-medicating, and that she found that no, they actually were better. But that was a really small subset, and that really should be handled by a psychiatrist. As someone like me, as a general geriatric doctor, as a general doctor, I would not do cannabis on patients um, who had schizophrenia. Now, conversely, I think there's something, not really conversely, but then there are certainly, some people who have cannabis use disorder. And I have a gripe with the DEA, not the DEA. I have a gripe with the DEA, but about the rescheduling, right? But I have a gripe with the DSM-5. Now, the DSM-5 is a handbook for psychiatrists about every psychiatric disease and what its code is and what's criteria and what meets the criteria of this disease and that. And every so many years, they come up with a new guidebook. And so the more recent one was DSM-4. DSM-4 was yes, DSM. The DSM Diagnostic Statistical Manual, I think. I think the S is statistical. Manual, symptom? I have to think what the S stands for. I'm not a psychiatrist. I just always call it the DSM. Um, is a four looked at addiction and said there were actually two separate things. There was dependence and there was addiction, and they called them separate things. So it understood that getting a tolerance to something or having to take something or you're going to get withdrawal symptoms is not the same necessarily. That's a physical dependence, but it's not the same as addiction, abuse. And abuse were things like, oh, what am I doing with am I doing this every day to the focus of work, or to the loss of work, right? Am I not working because I'm taking this? Am I not meeting my social obligations? Am I neglecting family and friends? Are people telling me I'm smoking too much? And do I feel like I should, but I can't? You know, these are some of the things that we talk about uh, in the criteria. And what they did in 5 is they put those together. So now you can get these mild cannabis use disorder, moderate and severe. And a lot of people with mild cannabis use disorder just are taking it every day for sometimes a medical condition, right? And they have, in taking it, developed a tolerance and a dependence in the sense that, if they stop it, they're going to get withdrawals. that gives them 2 points, which is mild cannabis use disorder. When you start getting into moderate and severe, yeah, these are people who are having it getting away with their life. And so I would say there's something to be said about that. And we have to be aware there are people who should not be using it, who we do need to talk about cutting it down, who we do need to say, is this helping you or hurting you? Are you using it to live your life or are you living to use it? Those are two different things, right? So, focus more on CBD. Yes. So now that's an interesting thing. Particularly, I don't know as much about the CBG for schizophrenia, but you're absolutely right that there's been some studies to show that CBD has been able to help with schizophrenia. Um, Fish oil too, the THC, though not THC, my tongue tied there. Fish oil, omega-3. So one of the things about like omega-3 is it actually works on the body as an endocannabinoid. I know I've mentioned that before, along with the omega-6s, but there's been some studies to say that omega-3, when given to kids who are high risk for schizophrenia, so these are people whose parents had schizophrenia or were already starting to maybe develop some early symptoms on some screening tools. They gave them omega-3 and it decreased the rate of developing psychosis. Now, there's also some studies, and this is what Terrell's talking about, that about CBD, that CBD worked as well as one of the major antipsychotics. I wouldn't necessarily suggest people trash their antipsychotics and take their CBD. That's don't do that. Not without talking to your doctor. But it might be a good adjuvant. It definitely kind of goes along with the idea that schizophrenia is probably going to show up to be some sort of problem with the endocannabinoid system. Again, it's criminal that we don't learn about the endocannabinoid system in med school, um, because it all kind of makes sense that at the area time in your life when you're doing neural pruning of the brain and you're myelinating the um, when you're myelinating that brain in your late teens, early 20s, that that's also the time when schizophrenia starts to kick up in the very late teens, like 17, 18, 20. Um, you know, when I was at the VA, I'd see a lot of schizophrenia, in fact, because people joined the military at 18, and then schizophrenia would happen when they were in their basic training or their early years. And so, um, it wasn't the military that caused the schizophrenia. It's just you joined the military at that time, 18, a lot of kids instead of going to college, right when the schizophrenia was starting to hit. Um, just as an interesting side note. But the schizophrenia happening at that time period, right at the same time, suggests to me that there indeed is a problem with the endocannabinoid system that's leading to this. Now, and it's interesting because things like CBD and omega-3, which kind of tap down some of that THC effects, make schizophrenia better. And then you hear about people at that age group who take THC who get psychosis, cannabis related psychosis. And some of them were likely prone to schizophrenia, already had it, or were starting to develop it and started to get symptoms. Um, At least that's kind of how I see it. And I'm sure there might be some experts who might have other opinions on it, but it makes sense to me. Now, CBG. Now, I have been reading more and more about CBG, and it's really fascinating because you're absolutely right. The stress, the anti-inflammatory, the effect to help with pain and inflammation, and that just feeling that people get, you know, that inflammatory pain, right? Or or just arthritis. CBG, not a lot of studies about it for sleep, and not a lot of studies. I haven't seen anything about it for schizophrenia, which is what I was saying. I hadn't seen anything for that. But you're right. And it's true. That's the whole thing is that kind of live in a world where there isn't a lot of research. I won't say guessing, but we're often taking preclinical data, rat studies, and trying to extrapolate it to human studies, and that can be a little risky, but, it's also the world we're in right now. Part of the problem, I think, and I was looking at this when I was reading some articles about sleep, is the lack of homogeneity, where everything's sort of the same. So a pharmacy makes a new drug, right? They make drug X. My new drug X, it's going to cure this, and this. They control the dosage. So they do a phase one. They say, okay, safe, not safe. Okay, safe, great. Then it's like phase two. Okay, what dosages are we going to use? And they kind of have a rough estimate based off of the animal studies already. And so they kind of do a range. And then they do phase three. Did it actually work? Did it help? We tried some different dosages. Was there a dose response? And then, FDA approval, then phase four, looking for side effects when you finally give it to millions of people. Right. Now, because the drug company controls that, you know, you get this sort of, it's always the standard drug. It's always these standard patients. It's always the standard stuff. And so when you're looking at cannabis data, it's not there because it's not one company doing it. It's company X who wants to show that their proprietary brand of cannabis oil helps this symptom. And they're not necessarily looking for FDA approval. They just, or maybe they're looking for European approval, but they're looking just to show, look, we can do it. You know, um, and then you have other people, have research people, they're looking at dronabinol. Okay, we can't get the illegal stuff. So let's just use dronabinol, the FDA approved synthetic, or Stativix over in Europe, right? You know, who was very much trying to get approval on different things. So they are doing a lot of these sort of standardized studies. Um, but when you look at all these, it's like test A looked at this drug and this dose and these group of people. Test B looked at this group of people. Test C. And we may have to admit that we may never fully get all of the answers until like you get a zillion studies and we can all do the meta-analysis to the point it makes sense. Because right now there are studies, but when you do the meta-analysis, you can't make sense of it because there's too much difference between the studies and what they're trying to say. And yeah, it needs to be studied more. But I agree. CBG, another thing that I am kind of interested in was reading a little bit more about where did it go? Um, oh, why did I just blink on it? Um, the There is another cannabinoid. No, it's yeah. I can't believe I blinked. Well, there's BCP, which we talked about a little bit last time. I know a lot of people were kind of commenting about that. And that was kind of interesting because that again, kind of like the terpenes, is found in other things like citrus fruits, cinnamon, cloves, curry. Again, though, not a lot of human studies. And so we're kind of limited, in our research on that. But it's a CB2 and it only works on CB2 and doesn't work on CB1, which is kind of interesting, you know, um, because that means that it's kind of helping with things like inflammation and maybe appetite or other things like that. And it could potentially have some good benefits. Another th- and then and then yeah, but there's other things too that are there's a lot more of these sort of cannabinoids, things that act on the cannabis receptors that are very interesting. Yeah, from black pepper. You know, and I wonder, there's a lot of studies about how turmeric and black pepper work together, and maybe there's a little bit of interaction there, right? Um, but again, not a lot of human studies. And of course, a lot of that is because of the legal status and, and people being scared to work with cannabinoids. Um, a terpene is a terpene regardless of origin. Right. That's true. Um, and like I said, a lot of the terpenes are from different things. I frequently will talk about my marigolds that I've been growing in my garden and hops. Exactly. Another thing that um, eat hemp seed. They are complete, right? Oh, actually, I got so teased about this years ago because I would, when I bake, put hemp seed in ground hemp seed into my baked goods because interesting. I would put hemp seed because of the protein actually. Less for the health benefits, though there's a lot of studies now again when we talk about the healthy fats that the hemp actually has a very healthy fat. It's part of the omega-3 family, right? Terpenes are not illegal, nor is BCP. Right? And it's weird that we still don't have that research. And I think part of it is also because while they're not illegal, they're also not, they're kind of considered herbals. And the ability to get research on herbals is so frustrating. You know, as a geriatrician, I have seen the rise and fall of ginkgo and several different herbals that were supposed to cure Alzheimer's. Take this to prevent Alzheimer's. Vitamin E was one. Everyone was like, "Ooh, vitamin E," and then they actually did the study. I have seen the rise and fall of vitamin D go from vitamin D. I still believe that a lot of people are deficient in vitamin D and need it. And when you don't have vitamin D, it is a very bad thing for you. But especially like in Chicago where I live, we just don't get enough sunlight. But they found that mega doses of it actually hurt people, increase their risk of falls, and a lot of what we believed about it wasn't necessarily true. I remember seeing folic acid being the next best great thing. And again, folic acid, great if you're pregnant. Folic acid, great for a lot of things, but it doesn't stop heart attacks. There's I've seen a lot of those things. Um, Omega 3 and 6 right now are things that we're talking about, right? Those are great. But what I think has happened is why we're not seeing these studies as much. It kind of actually goes back to what I was saying before. When a big pharma has their hands on a specific drug, they have a very standardized way they test. And because it's one company, they control the formulation, they control the dosage. My husband once did statistics for a pharmacy company, and they were developing a new drug at the time. And that new drug had, it was so standardized that they were trying to make it into a liquid, and they realized they needed to add some apple juice to make it tasty. So they ran across the street to the local Jewel and got President's Choice brand, and I don't even think they make that version anymore. Um, Apple juice. And when they had to do FDA approval, they actually had to specifically say this brand of apple juice. You know, that's how specific. And I'm sure at some point they had to kind of trade that out when, for whatever they actually use. But that's how detailed it gets. But when you have herbals, no one's like, no one's pushing a multi-million dollar thing to try to make this happen. And so that's um that's the problem with that. And so I think that's why the same reason we're not seeing the terpene research. And there's, another thing that excited me about pining, it's wound care abilities. They did actually do a study on that where they gave someone injury, a burn injury, a chemical burn, and then gave them pining versus just the carrier agent versus nothing, and showed that the pining actually helped the burn injury heal faster. I mean, the role of cannabis on wounds. Um, I think I've even mentioned it before that wounds you know, are a very dynamic thing. Our skin is alive. And so that interaction of wound healing, I would not be surprised if cannabinoids are part of it. If the CB1 receptor on our skin isn't part of what helps us heal. And that's why putting, CBD, THC on a wound, and pinene for that matter, helps it heal better. Um, the other thing, like pinene even has some antibacterial effects. I'm like, oh, I need some med honey with a little bit of THC, a little bit of CBD, a little pinene. Uh, Throw that on there, and it could probably heal up wounds pretty fast. Big pharma, if anyone wants to do that study, give me a holler. But anyway, cannabis has long chains like linoleic and oleic mostly, trace amounts of medium chains, right? You know, and it's interesting because yeah, those are the healthy things, like particularly hemp, you know, hemp seed. It's annoying because right now you have all these people who are like, "Ooh, seed oil's bad." I'm like, not all seed oils. Yes, omega 6 like sunflower, not good for you. But some of the things like the hemp seed oils have really nice oils in them. Trace amounts of medium chain. I didn't actually know that about them. That's actually very interesting to know. The and I think I've mentioned it before, but um the omega 6, while it's essential, while we need some, that there's a lot of research coming out showing that the the balance of 3 and 6 in our body is part of what's making us sicker. And I'm like, that kind of makes sense. So essential oils can be excellent for local first and second degree. Yes, which I mean, well, first just the oil itself, just that soothing stuff. Now, personally, I'm an aloe fan. First degree sunburn, I'm aloe all the way. I have my aloe plant in my house, and that's what I tend to use on that. But the fact is that there's a lot of herbals out there that are very important. And again, speaking of the terpenes, lavender oil is full of pinene, um, and so yeah, essential oils are great for that. The Now I know last time there was a lot of talk about THCV, and I know I put a post on it, but just to say real quick, one of the things that really surprised me, again, preclinical data. It's like, oh, come on, someone do a human study on this, please, because this is huge. This was a really cool thing. And that was to show that Parkinson's so in Parkinson's is the primary treatment is a drug called L-Dopa, carbidopa, levodopa, levodopa. Well, it's a combination medicine. One is the active medicine that works on the brain, on the area of the brain that's damaged in Parkinson's. The other is to prevent some of the systemic side effects and to help it be a little bit more focused up there. Anyway, so carbidopa, levodopa um, um, together help. But what happens is over time, as the disease progresses and as you give more and more and more and more and more of it, you start getting side effects where you get more stiff, you get dyskinesia. Sometimes you get dyskinesia. So that's Latin. Dys as in not good. Um, and kinesia, like kinetic energy movement. So you get these abnormal movements that aren't very healthy. Sometimes you can get a frozen, like a thing called torticollis, where your neck is frozen in a specific, or you can get abnormal movements. And sometimes people can get frozen, and they can get other things as the Parkinson's becomes less and less effective as the disease progresses, and the L-Dopa becomes less and less effective. And a lot of it is because you're giving it and your body kind of adapts to it, which isn't great because it's like, oh, you know, they found in rat models that THCV, if you gave it at the beginning, they had rat models for dyskinesia. They actually have Parkinson rat models and Parkinson rat models for developing dyskinesia. And so they induced Parkinson's and then gave them this. And then what they found was they gave it THCV with the L-Dopa. It decreased the time or increased the time it took to develop dyskinesia, which meant the L-Dopa worked longer, better, with less side effects. And then when they had mice who actually developed the dyskinesias, these abnormal movements, they they had a separate study where they had mice who had already developed them, and then they gave them THCV, and it improved. The symptoms improved. I'm like, God, we need this in human studies now. But again, for wound healing, yes. So, okay. So I believe this is a study. Let's see if I can pull it up here. It's not letting me do that. No, I'm not going to block. No. Uh-oh. No, I don't think I did. I might have accidentally blocked you, William. I hope not. I'll get you off if it is. Um, but okay, thanks. Good. You're able to put it back up. So, yes. So there is a lot of studies about cannabis and wound. Let's see if I can't get that one up here. It's not popping up on the screen right now, but y'all just have to take a second there and just say that it is there. And yeah. So there is some real studies to show that cannabis helps wounds. Again, on our body, on our skin, we have different receptors. Why do we have cannabis receptors on our skin? Right. Um, it's not like we're feeling, it makes sense we have TRPV heat receptors or pain receptors, but why do we have cannabis receptors on our skin? And I think one of them is it's involved in like skin homeostasis. Again, that kind of balance of how our skin works. Um, Interestingly enough, there's a number of diseases. So, you know, again, nerve damage, right? So you may remember, does anyone remember Superman, Christopher Reeve? Back in the day, the actor who played the Superman back in the 80s, right? Christopher Reeve, he fell off a horse and broke his neck at a very high level, such that he needed to be on a ventilator for the rest of his life, right? Um, but, he had money, he had a foundation, he had all this stuff that he had access to. And of course, he had people who were more than willing to help him out because they could say, "Hey, we helped Christopher Reeve. It was good for um, their cred and their advertisements, right?" And so he had all the resources um, available, and he still died of an infected bed sore. And the reason is because there's a level in the cervical spine below which, if or above which, I should say, if you break your neck, the transmission of the parasympathetic, the one of the you have sympathetic, which kind of activates, parasympathetic, which sort of deactivates, fight or flight, rest, and eating and the digestion, right? And those kind of different two functions that gets interrupted. And so, among other things, the skin doesn't get the input it needs to stay balanced. So when you get cold and you get goosebumps, you get hot and your skin turns red and it flushes and lets off heat. That's an autonomic as in like automatic with you not even have to think about it, right? So that's a system, that's an automatic system that happens in our body. It's not surprising to me that cannabis would probably not cannabis, but the CB1 receptors play a role in that. But also, not only does it happen in high level spinal injuries, it happens in Alzheimer's. So many people with Alzheimer's, you know, get bed sores. Now, yes, sometimes they get bed sores because they are completely neglected and they're in their bed and no one's turning them and you're supposed to turn them and you're supposed to help them because they can't move. And, yes, sure, without a doubt. But in the first descriptions of Alzheimer's, Professor Alzheimer's actually described Alzheimer's as having bed sores despite good nursing care. That's just to say that you can have a bed sore regardless. And I suspect that there are some people who are very prone to it because the Alzheimer's probably breaks down this pathway too. And so, again, it's not surprising to me that a CB1 receptor might do something to promote healing in these bed sores and prevent it, maybe even, but definitely promote healing. And so that is real. We are at 3:58. Oh, you guys are great to talk to. We keep getting these nice conversations and the time flies. It is wonderful talking to everyone. Thank you everyone for your input. Um, I have a 4 o'clock call that I have to do where I'm going to be doing a podcast about sleep. Like I said, didn't talk too much about sleep today. Don't want to take away from her steam here. And when she has it published and up, I'll let you all know. So it'll be available so you can see it. Um, Wonderful talking to everyone. I hope you all have a great day. Stay safe, stay well, stay blessed. Um, and take care. I'm going to sign off just about a minute early so I can get going onto that other call. Y'all have a great day.